SPI lectures today. I'm your regular anchor, Negedu Godwin. And my appreciation goes to these wonderful people who have contributed immensely to my knowledge, for which I'm most grateful. So we're going to be looking at principles of pulse echo imaging and display modes. And if you've not seen the introduction to SPIs and other follow-up lectures, please, you'll see the link in the description. Follow it and your knowledge will be deeply enriched. So how do ultrasound system work? So in a pulse echo system, the ultrasound pulse is generated electrically by piezoelectric crystals that is inside the transducer. So the transducer is coupled to the skin with acoustic gel, and the pulse of the ultrasound propagates down into the tissue. So at the acoustic interface in the body, which will include specular, reflector, and scatterers, a portion of the incident beam energy is reflected and returns to the transducer. Now, this transducer converts the returning echo into electrical signals, which we call RF signals. And each RF signal is then digitized and amplified, and the further gets to be electronically processed. Now, basically what happens in the electronical processing is compression, demodulation, and rejection, with other things we'll get into shortly. And after that processing is then stored in the memory at an address location. So once all the address location has been filled, the data is read from the memory and sent to the TV monitor to be displayed as an image that you see. Now, the position or location of an interface is largely determined by the go-return time of echoes. Now, the go-return time is the time that elapses between the transmission of the pulse and the reception of the echo. So since the sound travels at a known constant speed of 1,540 meters per second in soft tissue, the depth of the interface that produces the echo can easily be calculated from the go-return time using the range equation. In a grayscale display, now the brightness of each echo is determined by the amplitude of the echo, of the echo's RF signal, which is proportional to the strength of the returning echo. That is the percentage of reflection. So strong echoes will display brightly on the screen. Medium echo strength will appear gray, and weak echoes will appear dark on the screen. So in the past, echo signals were displayed on the TV monitor in many different formats. Like we had the A mode, the B mode, the M mode, and the B scan. But today, the grayscale real-time B scanning, along with the M mode for cardiac applications and for fetal heart, is predominantly used these days. So now all systems are digital, and they digitize the signal. So let's look at digitization. What does it mean? It simply means to assign the signal a number that is proportional to its amplitude or strength. So for example, the amplitude of an echo that is coming back from a strong reflector like the adult diaphragm might be assigned the number 100, yeah? While a weak echo from soft tissue might be assigned the number 25. So basically that's what you do in the digitization. Now to maximize the number of, to maximize the use of the instrument, there are many operator adjustable controls that are available which affects the information on the image. Now, the major components in the scanning device, the machine, are the pulsar, which you also call the transmitter, the transducer, you may want to call it the probe, the receiver, you may want to call it the amplifier, the memory, also known as the scan converter, the TV monitor, of course, is a video display, and the recording devices. Yeah, several of them. We'll look at them in a moment. Now, this image shows you a schematic diagram of those, how the components are linked to one another. These are the major components. There are other things, but these are the major components that does the job of digitization. So let's jump into the pulsar or the transmitter. Now, the pulsar produces the electrical voltage bursts that are sent to the transducer. And in response to each voltage burst, the piezoelectric crystal in the transducer vibrates to produce pulse of ultrasound. So what the pulsar does is, it does not supply electricity continuously. It generates electricity in positivity, in positive form. So the transmitter or the pulsar has two components, which is the pulse generator and the clock generator. Now the pulse generator produces a short amplitude electrical voltage that is sent to the transducer. Now this short voltage is called excitation voltage or shock excitation, which is an analogous to striking a bell to make it ring, yeah? So remember, what it does is it sends voltages in small bursts. So the initial amplitude of the ultrasound pulse that is generated by the transducer is determined by the amplitude of the excitation voltage that is applied to the transducer. A stronger excitation voltage produces a stronger ultrasound pulse, which will penetrate further into the tissue. Now, manufacturers use alternating current, AC current, yeah, as excitation voltage, which has a known frequency. So by changing the frequency of the excitation voltage, this transducer's ultrasound frequency can be changed without changing the transducer. Now, so remember that this is the amount of pulsatile voltage that gets into the transducer that gets it excited to produce the amount of the pulse wave that is sent out. So the amplitude of the excitation voltage is typically 150 and 300 volts. That is about 1 second in duration. So the operator should regularly inspect the transducer cable for cracks or breaks that might cause the operator or the patient to receive an electric shock. That is in the area of quality assurance and maintenance. We'll look at that in some other lectures. So the clock generator, what it does is it controls the number of excitation voltage that is sent to the transducer. Now, this determines the PRF. It is also responsible for sending timing signal to the other components in the system so that each pulse echo sequence can be accurately timed. The clock generator tells the receiver when each pulse is transmitted so that when each echo is received, its go return time can be calculated. Now, this allows accurate location of each echo using the range equation. It also enables the TGC, that is time gain compensation device, to apply gain compensation to each echo on the basis of its go return time. The output power control is controlled strictly by the operator. Now, this control determines the amplitude of excitation voltage, and it determines the amplitude of the transmitted pulse. Remember, the amplitude of excitation voltage corresponds to amplitude of transmitted pulse. Now, this control is usually labeled as power output or power output in your machine, depending on what the manufacturer depends to label it. So if the output power is increased, a higher amplitude excitation voltage will strike the transducer crystal, resulting in a higher amplitude ultrasound pulse. When you decrease the output power, it reduces the amplitude of excitation voltage that is producing a lower amplitude of ultrasound pulse. Now, when you increase the output power, you increase the depth of penetration. However, it also increases the acoustic exposure to the patient. Now, due to our concern for patient safety and our aim of minimizing the change of adverse biological effect, the output power control should be set at the lowest setting that does not compromise the image quality. So the power output control on many systems is labeled in decibels. Yeah. So 0 decibel is maximum power, minus 3 decibels is equal to half the power, minus 6 decibels is 1/4 of the power, minus 9 decibels is 1/8 of the power. So that's what happens at the pulsar or transmitter. Now, burst of voltages has been sent to the transducer. So what happens in the transducer? The transducer contains piezoelectric crystals, and in response to each of those voltage bursts from the pulsar, the crystal in the transducer will vibrate, converting electrical voltage into pulse of ultrasound. Now, each voltage burst from the pulsar produces one pulse of ultrasound. After each ultrasound pulse is transmitted, the transducer then starts to receive returning echoes that is produced by that pulse. Now, upon reception of each echo, the transducer vibrates again to convert the echo into tiny electrical volts or voltages that you call the echo signal. So from the transducer, the echo signal is sent to the receiver. So basically that's what happens at the transducer. The excitation of the piezoelectric crystal to produce pulse wave ultrasound, and the reception of echoes which excites the piezoelectric crystal to produce tiny electrical voltage. So this tiny electrical voltage is sent to the receiver. So what happens at the receiver? The receiver is the third major component of the ultrasound system. And what the receiver basically do, it receives echo voltage from the transducer and amplifies it. That's why you can otherwise call it amplifier. So what does it do when it amplifies? Each echo that returns to the transducer generates a weak electrical signal you want to call RF signal. The first step in processing each returning weak echo signal is to amplify the RF signal. So the operator controls the amplification with the overall gain control. Remember your gain knob? That's what you are doing when each time you push that knob. So the overall gain control amplifies all the RF signal by the same amount. So if you're amplifying by 2, you're amplifying all the RF signal by 2, regardless of the amplitude. Now this would then increase the brightness of all echoes in the image by the same amount. So it can be described as a linear amplification. Now note that an increase in the output power can also be used to make image brighter. However, an increase in gain should be the operator's first choice than increasing output power. Remember, we're looking at patient safety. So you want to use your gain first before you consider the output power. So gain does not affect the patient exposure, yeah? And since it's performed on reception and not on transmission, so you look at the choice of gain over power, and that is the reason, because it's applied on reception and not on the transmission. So what is the effect of changing the overall gain control? Now what happens basically, the imaging effect of increasing the overall gain control makes all echoes brighter on the screen. Now when you decrease the overall gain, it makes all echoes darker. Now the operator must adjust the overall gain appropriately. Now if the overall gain is too high, it overloads the display, making interpretation very difficult. On the other hand, if the overall gain is too low, the image will be too dark and weak echoes may not be displayed. So you get to lose information. Therefore, overlying high gain settings can also enhance the display of confusing artifacts. So when you have an artifact and you increase the gain, it exaggerates the artifact, and that creates some level of confusion. The clinical approach to setting the overall gain is to set it high to start, then you reduce it to a point where the image is optimal. So if you are new to the practice, start with high gain, then adjust it low until you've achieved an optimum image quality. So compensation, how is compensation done? So one of the imaging goals is to display all your similar reflectors with the same brightness, regardless of their location in the anatomy. For example, we would like to display the entire normal lever with uniform brightness, regardless of its depth. Yeah? But remember that attenuation will reduce the strength of both the transmitted pulse and the returning echo. So the longer the path length that the sound will have to travel, the weaker the echo becomes. Now, because of this attenuation that is due to depth, echoes from deeper interface will be weaker than the echoes from superficial ones and would be displayed with decreased echo brightness unless attenuation compensation is applied. So that's the place of your TGC. So we need to know how to use our TGC. And without the compensation, the TGC, echoes from deeper, for example, lever, would always be darker than the echoes from a more superficial liver tissue, even though the reflecting tissue is the same. And you don't want that to happen, because you really need to know what is going on in the liver. So how does TGC work? Let's take a look. Now, the TGC is the control that compensates for the depth attenuation, or the attenuation that happens as the sound goes deeper and echo returns, or the attenuation that will occur will be compensated for by the TGC. Now, the TGC basically, the TGC amplifier, when it's applied, increases amplification to the returning echo signal based on the go return time. TGC applies only a small amount of amplification to the echoes that are having shorter go return time and must have return from the superficial structures. Now, TGC applies more and more amplification to the echoes that are having longer and longer go return time and must have been returned from deeper structures. So the TGC controls applies amplification in proportion to the echo time or the depth of the tissue. So it's also called depth gain compensation. And this image shows you what the TGC is like, and we'll talk about the setting of the TGC in a moment. So the operator controls the TGC and can use it to change the degree of amplification at selected depths to optimize image quality. As you have with the overall gain, the TGC also is a receiver function, and it does not affect acoustic exposure or the intensity to the patient. So the TGC compensates for depth attenuation. Therefore, the slope of the TGC curve is determined by those factors that contribute to attenuation. So what are the factors that contribute to attenuation? Tissue characteristics, or the composition of the tissue, attenuation coefficient, transducer frequency. Now, if any of these factors is increased, then the slope of the TGC should also be increased to compensate for it. For example, the slope of TGC should be increased if there is fatty liver, or if the sonologist switches from 3 MHz to a 5 MHz transducer. In fact, many modern systems will do this automatically whenever the sonologist will change transducer. So compression happens at this point too. So the transducer are actually capable of detecting a wide range of echo amplitude. In the study of other videos, we talked about this. Now, the other components in the ultrasound system are not as capable, but they had to deal with such a wide range of signals. So this wide range of signal amplitudes that is received by the transducer must be reduced. And there's a socket in the receiver that can do this, and that socket is called the compression. Now, compression reduces the range of echo amplitude by reducing the difference between strong echoes and weak echoes. It does this by amplifying all the echoes, but it amplifies the weak echoes more than the strong echoes. It's also known as a non-linear algorithmic amplification. So algorithmic amplification gives more gain to the weak and less gain to the stronger echoes. Thereby, it will reduce the difference between them. Now, this is called reducing the dynamic range. So this is an example of how it's done: the pre-compression and the post-compression. So stronger echoes are seen here, but when it's compressed after compression, you see they are almost equal, but they are not equal. So dynamic range is the measure of the range of echo amplitudes that can be handled by different components in the ultrasound system, which will include the transducer, the receiver, the memory, and the video display. It is the difference between the strongest signal and the weakest signal that each component can handle. It can be expressed as a ratio of strongest over weakest, and is usually expressed in decibels. A good transducer has a dynamic range of approximately 100. This means that it can handle variation of voltage amplitude by a factor of 100,000. Now, this table describes the typical dynamic range and the corresponding amplitude and intensity ratio of system's principal components, the main components in the system. So here you can see that the transducer can handle 100 decibels in dynamic range with an intensity of 10 billion to 1, and amplification ratio will be 100,000 to 1. And you can see that for receiver, scan converter, and video monitor. So the dynamic range is reduced as the signal moves through the system components. It is highest at the transducer, then is reduced as the signal moves to the receiver, then to the memory, and finally to the TV converter. It's all about adjusting the signals in a way that the other components can receive them. Signal to noise ratio. Now, this is an expression which compares the real echo signal to the system. It compares the real echo signals the system can handle to the non-echo signals present in the system, that is the noise. So the higher the value of this ratio, the better the operation of the system. The receiver can also set the electronic noise level within the machine determined signal to noise ratio. Demodulation. What happens with demodulation? So demodulation is actually another process that is carried out in the receiver. It is the electronic processing of simplifying the shape of the RF signal so that it can be more easily handled by the memory and the TV monitor. And there are two components in the process of demodulation: the rectification component and the smoothing component. Now, unlike the overall gain, the compensation, compression, the operator does not have any control over demodulation. It is applied to all RF signal that is passing through the receiver, and is done without any input from the operator. So in rectification, there is a conversion of the RF voltage from a complex modulating AC wavelength waveform to a simpler demodulated DC waveform. So the entire negative half cycle has been flipped to a positive cycle. And smoothing is also a filtering or enveloping, and is then applied to the rectified signal to remove all the small variations that remain. Now the result is a simple positive spike of signal that can be easily handled by the memory and the TV monitor. But one thing happens before we move from this point is a rejection, and this is actually the final process. Now it is the process that removes some RF signal from the system. The signal that are removed are those that have lower amplitudes than the rejected level or the threshold level. Now, it is a type of high-pass filter, allowing the higher amplitude signal to pass on, but rejecting the lower amplitude signals. So rejecting is done because much of the noise in the system is low amplitude noise. So if the low amplitude RF signals are removed, then most of the noise will also must have been removed. So in some systems, the rejection level can be controlled by the operator, while in some you can't do that. This will raise the threshold level. When you raising the threshold level will remove even more of the RF signals. When you lower the threshold level, it removes fewer RF signal. Now, if you have the ability to control that, you have to be careful what you're removing and what you're adding. But it's worth doing if you have the opportunity to do that. Well, in Doppler system or echocardiography system, typically would have the operator control the rejection. Yeah, while those that are designed for abdomen, obs and gynae ultrasound will not give you the opportunity to reject in some systems. The reason for this is that echoes returning to the transducer from soft tissues in the abdomen have a wider range of echo amplitudes that compared to the heart or vascular system. So if the threshold level is set too high in an abdomen scan, valuable low-level echoes with information from a normal tissue is not processed, and the accurate interpretation will be compromised. So to avoid this, most manufacturers typically do not put rejection control on these machines. But on the other hand, in the echocardiography and Doppler systems, there's less risk of misusing the reject control. So in majority of these examination, the important information in the image is a compromise of moderate to high amplitude echo. Therefore, even if the rejected level is set high, since the majority of the RF signals needed to make the diagnosis are high amplitude signals, these are not being rejected and will still be processed. The memory, now we've rejected and all that. So now we are in the memory. What happens in the scan converter? That is the component that puts the image together. Yeah, the memory consists of a matrix, which again is divided into small boxes called pixels for address location. Now think of them as pigeonholes. Yeah, so each echoes from the receiver is evaluated for two parameters or characteristics, and they are when the echoes come, it is evaluated for time. What's the time allotted to it based on its go return time? Yeah, and the other characteristics or parameter that is examined in this particular echo is the echo amplitude, the strength. So when the tag on that echo is done based on these two parameters, the echo location is then determined from the time, and the echo brightness determined from the strength. So when each echo signal is received from the receiver, it is stored in memory at a correct location in the pigeonhole. Remember the matrix? Yeah, and is assigned a number, a binary number on its amplitude. As each echo is received, it is stored in memory until a complete image is created. So you have your pigeonhole, as the echoes come is evaluated and is placed in the memory. It's placed according to their time and echo signal. So those two characteristics will determine the location and the brightness. So it keeps on putting those information in the memory until a complete image is created. So once all those echo data for one complete image has been stored in the memory, the data now can be read from the memory and sent to the display. Now what happens at the display is this. Remember, is the TV display, yeah? The image information is read from the memory and displayed on the TV monitor as shades of black and white. That is in a shade of 64 shades of gray, right? So strong echoes are white, what you want to call highly echogenic. Mild echoes are gray, you want to say is echogenic or is echogenic to hypoechogenic. And very weak echoes are almost black, what you want to say echo poor or sonolucent. And no echoes are completely black. If it's an echo, it's not black. It may just be echo poor. Where there is no echo at all, then it's completely black. Black means no echo. Ultrasound system will produce real-time sequential display of gray scale images with a frame rate of 15 to 30 frames per second, so that our eyes can perceive a real-time image that does not flicker. So besides the TV monitor, we have the recording device, and these are used to obtain either the soft copy or hard copy of the image for temporal or permanent store in the scan. Now, many different recording devices can be used. These are the thermal printer, the multi-format film camera, laser cameras, videotape recorder, floppy drive, CD-ROM, DVD. You can use Blu-ray devices, pen drive, HIS, RIS, or PACS. And PACS actually mean patient archiving and communicating system. So these are recording devices that can be used. So thank you for joining this lecture. I believe you've learned some things that will set you on the right path, and those of you preparing for exam, your information will help you greatly. I want you to subscribe to our channel, like and share this video, and you can leave your questions in the comments. Also attempt our quizzes that will boost your knowledge. Until I come your way again, keep learning ultrasound.